In this second part of the lecture, we're going to have a look at odontogenic tumours that comprise odontogenic epithelium alone as their neoplastic component. There are a number of these lesions. The most common of these is ameloblastoma, which we have already talked about, but there are other lesions such as the adenomatoid odontogenic tumour, the calcifying cystic odontogenic tumour, and the squamous odontogenic tumour. Top three of these I'll spend a little bit of time talking about in this section. The squamous odontogenic tumour I'm not really going to talk about much more because it is extremely rare. Ameloblastoma itself is a benign odontogenic tumour, but it is locally destructive, and we'll see some examples of that in a minute. As far as epidemiology is concerned, the vast majority of them arise in the mandible, most of them at the angle, and that's in keeping with the fact that they arise from the remnants of the dental lamina, which are most commonly found in the tissues at the angle of the mandible. The age range tends to be about 30 to 50 years of age, although you can arise really at any ages out with that as well. Clinically, at an early stage when they're small, they are often asymptomatic. But buccal lingual expansion can be quite prominent with them, and this can be a useful thing in distinguishing this from an odontogenic keratosis, in which there doesn't tend to be very much buccal lingual expansion. As it is a rather destructive lesion, there is often root resorption and or displacement of teeth associated with it. As far as the radiographic appearances are concerned, it can be a uni or more commonly a multilocular radiolucency in the mandible. Here I have a clinical picture, which you can see a large expansile lesion of the mandible, which has resulted in quite prominent facial disfigurement. In this case, it does make a point that these lesions, for reasons that we're not entirely sure, are more common in black populations. And in fact, we do have a number of ongoing research collaborations with researchers in Nigeria, where the ameloblastoma is a relatively common tumour. Radiographically, you can see quite an extreme example of a large lesion in the half OPT that you see here. The lesion itself arises probably from about the parasymphysis and extends to the sigmoid notch, the base of the condyle. It includes the coronoid process. And it's multilocular, you can see various compartments within it. And it also looks as if there's quite prominent root resorption and displacement of teeth associated with this lesion. In many cases, we find though that this is much more like the size of lesion that we would get in the UK, although we do get some larger, more extreme examples. And so just stepping through the standard things that you'd be looking for, talking about the site of the anatomical position. So this is a lesion which is arising at the angle of the mandible. It's superficial to the inferior dental canal. It is probably about 3 or 4 centimeters in dimension anteroposteriorly. The shape of it, it's relatively well defined. It's not all corticated, and it is multilocular, so it looks as if it has got multiple different compartments to it. Its relative radiodensity is that it is radiolucent, and as far as effects on surrounding structures are concerned, it looks as if there is root resorption of both roots of the lower 7 and the distal root of the 6. Here's another example of a very large lesion. It looks as if there is quite prominent expansion into the oral cavity in this case. And again, you can see all of the features that we've talked about in terms of the multilocularity. It's relatively well defined, not always corticated. And in this case, the multilocularity has multiple small locules, sometimes described as a soapy bubble appearance. And there's also evidence of root resorption in this case, as in the previous one. Whilst most of these patients with ameloblastoma are in the age range of 30 to 50, it can occur out with that. And here's an example of a child, probably about 5 years of age, with a multilocular radiolucency of the left body of mandible, and this was an ameloblastoma. But that is very rare indeed. As you can imagine, when there is a large radiolucency in the mandible, particularly multilocular and expansile, sectional imaging is really very important to formally assess this lesion. And here you can see in these CT scan slices, in this case, there is a large radiolucency in the left body and angle of the mandible. It's multilocular, you can see various compartments to it. And there is one thing particularly of interest here that the surgeons are very keen to know, is that is the lingual cortex of the mandible intact? And you can see in the right-hand panel that in fact it is not. And that raises a particular problem because it is then possible that the tumour has escaped the confines of the jaw and may then be growing into the soft tissues of the pterygoid region. And that makes the surgery and the morbidity associated with treatment much more. We can use these sectional images to provide a 3D reconstruction. And here we have, again, another lesion which is in the posterior body and the ramus of the mandible. We can see the expansion at the lower border, and you can also get an impression of how multilocular with these strands of tissue which are separating the tissue into various compartments. All that I've shown you so far are mandible cases, and that does account for about 80% of ameloblastomas, but some do occur in the maxilla, and here's an anterior maxilla lesion. It is, again, radiolucent. It doesn't look as if it's particularly multilocular, but it's quite a scalloped outline to it, and it's obviously expansile as well. I'm going to come back to talk about treatment a little bit later on, but most of these lesions, at least historically, will have been treated by excision. That is a segmental excision of the area of the jaw affected. So we gain a little bit more information about the pathology if we have a look at a segmental excision. As you can see here, this is a portion of the mandible. You're looking at it from the lingual side. It comprises from around the area of the canine all the way back to the retromolar pad. And you can see that there is an expansile lesion which is bulging into the lingual tissues, but it does look as if the periosteum is intact in this case. If you're to radiograph this lesion, this is the sort of thing that you might see, and it has a number of the features that we've already talked about in the OPTs that we've looked at. It is a multilocular radiolucency. It is relatively well defined but not corticated in all places. It's probably about 5 or 6 centimeters anteroposteriorly, and there is evidence of root resorption and that bowing of the inferior border of the mandible that we saw in the previous gross image. When sectioning a case like this, you think, well, is this a tumour or is it cystic? Well, what we often find when we section the excisions like this is that a mixture of both cystic and solid components to it. And particularly very large ameloblastomas are most likely to be predominantly cystic. And that means there's a possibility of decompressing these, which is another controversial area in terms of the treatment strategy for ameloblastoma. Here is a gross image that you might see if you came to the specimens which are on the third floor in our small museum. This is an ameloblastoma, and again you can see how expansile the lesion is, and all the little compartments and the internal septae that are separating that in this lesion. But what about this histologically? Well, histologically, and there are some subtypes, and they sort of merge, at least initially, into some clinical subtypes. There is the sort of classic conventional intraosseous ameloblastoma. There is a unicystic form, which rather than being multilocular is a single cyst. And there are some interesting biological things about that, which I'll talk about in a minute. And then the peripheral one. And that is a tumour which arises out with the bone of the jaws. It's in the gingiva. And if there are some suggestions about what the biology of that might again be different from the conventional type of ameloblastoma. But the vast majority of them are conventional ameloblastoma, and when we have a look at them, there are two main histological patterns that we see, which are follicular and plexiform. And in practice, we find that most tumours will have areas of both of these histological appearances, and which one dominates doesn't dictate how the tumour behaves or anything like that. So this is a follicular pattern of ameloblastoma. And I know this takes you all the way back into the earlier part of the course when we were thinking about tooth development and the formation of the tooth bud and the ameloblasts around the outside and stellate reticulum in the middle. And what ameloblastoma does is, to an extent, it recapitulates that. There are columnar ameloblast-like cells around the periphery of the islands of the tumour, and then in the centre it's much less cellular and it is more like stellate reticulum, which we see in the developing enamel organ. And when you get cysts forming in a tumour that's dominated by follicular pattern, it's actually cystic breakdown in the stellate reticulum-like areas that allow the cysts to develop. And you see another example of follicular ameloblastoma with the cells lined up around the outside, a predominant stellate reticulum-like appearance, and in fact, and the island towards the top of the picture is beginning to break down into a small cyst. The plexiform pattern of ameloblastoma really has no stellate reticulum-like areas. It's just the basal ameloblast-like cells and cords and little knots of them, but no stellate reticulum. And here, when this becomes cystic, the cysts tend to form in the stroma. And so these are the two types that we find in conventional ameloblastoma, and the behavior is not dictated by which or other of these we get in the tumor. Now, about 10 to 15% of ameloblastomas are unicystic. Now, that means that there is a single cyst. They're not multilocular. They're much more simple than the large ones that I've shown you. Now, this is a rather controversial area because there appears to be a difference in the biology between those unicystic ameloblastomas which actually genuinely are unicystic. There is a single cyst, and that might be lined by ameloblastomatous epithelium, as you can see in the far left, or it may even have a proliferation into the lumen, but there's just a single cyst. In comparison to that, a conventional ameloblastoma that's dominated by a single cyst but does have some other proliferation into the wall, and we term that the mural type, and then there's the classic multicystic ameloblastoma that I've shown you. So there does appear to be a difference between these first two, the luminal or intraluminal type, and the others. And those which are genuinely single cyst ameloblastomas can be enucleated and the recurrence rate is low, whereas those of the other type have to be treated differently, and there's a tendency towards being excised rather than enucleated. However, despite the fact that this paradigm of these different types has found its way into the literature, there actually is genuinely very little support for this, although there is some now beginning to emerge. So this makes this area really quite challenging, not only for the pathologist, but for the surgeon as well, in terms of deciding how to treat a patient. So here is our luminal type, the lumen of the cyst at the top, the cyst wall here, and ameloblast-like cells on the basement membrane, and then some stellate reticulum-ish appearance, and then the cyst lumen. Just a single cyst. And this is the intraluminal type, where we've got, again, the epithelium round the lining of the cyst, and then there's a protrusion of ameloblastic epithelium into the lumen, but there's no growth into the wall. And so these are just these single cystic ameloblastomas. So what do you do with an ameloblastoma? Well, many ways for conventional ameloblastoma, particularly the large ones, they need to be excised with margins in order to minimize recurrence. As you can imagine, these patients tend to be quite young, and so that is going to be very destructive. And whilst in general terms that is true, there are a number of very prominent surgeons, a number of researchers who are suggesting that in fact that may well be overtreatment, and there may well be other more conservative methods, including decompressing the cysts and allowing them to shrink before removing them, which might help and reduce the morbidity of treatment. But generally speaking, in order to minimize recurrence, conventional ameloblastoma, that's 85% of all ameloblastomas, needs to be treated radically and needs to be excised. If you have a true unicystic ameloblastoma, which is actually not very common, they can be enucleated, and you tend to have a relatively low recurrence rate, and these lesions are followed up. When there is excision, and the times when excision does happen, it needs to be essentially done in the same way as a cancer resection with reconstruction, and many of the ameloblastoma cases are in fact discussed at the MDT. But the biology of ameloblastoma is increasingly being understood. And a lot of research workers are looking at particularly the genomic background of ameloblastoma, and they've identified a couple of dominant features in the genetics of it, and particularly those which have tumours which arise in the mandible. They seem to have a mutation in an oncogene called BRAF, and those which are tumours which arise in the maxilla seem to have mutation in a gene called smoothened, or SMO. Other mutations have been identified, but the fact that smoothened mutations and BRAF mutations don't tend to overlap might indicate that the biology of a maxillary lesion and a mandibular lesion is a bit different, and they might be slightly different lesions. So that's an area which is moving on, and they're also looking for new targeted therapies related to these particular mutations. What about adenomatoid odontogenic tumour? Well, this is a bit different. This is a benign tumour, but it is not an expansile and destructive lesion. And in fact, when treated, it doesn't recur. And many people believe that rather than being truly neoplastic, that it's a hamartoma. And that is borne out by the fact that it tends to occur in patients who are in the growth period, so it's from ages 10 to 20, more common in females, and most often in the maxilla, in particular associated with unerupted upper canines. And how they present, very often incidentally, with the fact that the canine hasn't erupted, there tends to be a radiolucency around the tooth crown, and then if you look carefully, you might find that there are small calcifications. The differential diagnosis in almost every case would be of a dentigerous cyst because it has the same overall appearance on radiology apart from the calcifications. The histology I'm going to show you, and the fact that it's enucleated seems to cure it. They don't tend to recur at all, points to it being a hamartoma. So here is our radiograph, our classic radiograph of an unerupted maxillary canine with a pericoronal radiolucency. You can see that the radiolucency looks as if it is attaching on or around the amelosegmental junction, as would be seen very often in a dentigerous cyst. But there is a background of fine calcifications, and sometimes that's not picked up on the radiograph. And it may be the fact that it could be an adenomatoid odontogenic tumour would be picked up by the surgeon, who finds something a little unusual at surgery, or later on by us as pathologists. But it's not only maxillary canines. Here's a nice example of an adenomatoid odontogenic tumour on an upper central incisor. You can see the radiolucency again, pericoronal, looks very much like a dentigerous cyst. So what about the histology? Well, it does what it says on the tin. Adenomatoid, duct-like. And so an adenomatoid odontogenic tumour has little structures in it which look like ducts. There are sheets of cells, there's even some cells around the outside here which look a bit like ameloblastoma. But the key thing which allows us to make the diagnosis are these duct-like structures within the tumour. The calcifications are related to the fact that it produces a kind of dentinoid type calcified material. It's not thought to be true inductive dental hard tissue change, because then it wouldn't be just in group 1, because you'd have to have odontogenic mesenchyme. But there's this material which over time will increase and give you that slightly snowstorm appearance on the radiograph. The third of these tumours is the calcifying epithelial odontogenic tumour. Now, this was originally described way back in the 1950s by Professor Jens Pinborg, so in some cases and in books and papers you might find it referred to as a Pinborg tumour. In terms of its clinical appearance and its natural history, it tends to act much more like ameloblastoma. It is benign, but it is and can be very locally destructive. It occurs over a wide age range, with most of them again in the mandible, and a good proportion of them associated with an unerupted tooth. As it says in the name, it is calcifying, so you then may expect that you will see some form of calcification on the radiograph, and that tends to increase with the age of the lesion. The very early immature lesions don't tend to have very much calcification at all, but later mature ones do. And the epithelium looks a bit different again from ameloblastoma and AOT, with a rather kind of funny looking epithelium with a lot of different size of shape and cells. The treatment for it tends to be, for ameloblastoma, they need to be excised rather than just enucleated or curetted. So here's an example of a lateral oblique radiograph looking back in the inside surface of the mandible, and you can see a destructive lesion. It looks as if the lower border of the mandible has been lost, and then there's a lot of calcification being formed in the center here. This sectional part of an OPT, you can see a much smaller lesion, and this is a lesion at the early stage of the development of a CEOT. It is vaguely multilocular. It looks as if it extends probably from about the first premolar and back to the area in between the first molar and the second molar, with looks a little bit of compartmentation to it. It is predominantly radiolucent, and in this case is not associated with an unerupted tooth. But this one is. And again, you can see this is quite a larger lesion extending from about the premolar region to the retromolar pads, probably about 4 or 5 centimeters in diameter. It's quite nicely demarcated, and in fact is mostly corticated, but it looks as if it's got some calcification beginning to appear in it, and there is a associated unerupted tooth that looks as if it is a bit displaced. The histology of these lesions is very different from the other two tumours that we've talked about, and there are two main components to it. There is an epithelial component, which you can see here, and there's these big flat cells with lots of prickles joining them all together, and you can get quite marked variation in the nuclear shape and size of these cells. And then we have this amorphous material, which is shown to have been some form of enamel matrix, which is being produced by these cells. And that, once it's been produced, can calcify, and in fact you can get quite large areas of calcification. The very deep pink here are the areas which are calcified, and there's lots of little areas of calcification scattered throughout this tumour. And when that gets widespread in the development of the tumour, then you begin to see that as radiopacity within the radiograph. Some of them are very cellular. Here's just a sheet of cells, again with a bit of calcification in the center, and that enamel and amyloid type material, which we can stain for and prove that it actually is that. And these tumors are quite variable in terms of their histological appearance and can sometimes be quite a challenge for us to diagnose. Now, as we finish this section, I just want to come back to something that we picked up in this cyst area. Now, is the odontogenic keratocyst a tumour? Because had we been doing this lecture a few years ago, we would still have been in the circumstance when the odontogenic keratocyst was, according to the WHO, the keratocystic odontogenic tumour. It was a neoplasm. Now, some people believe there's really good evidence for that. And that can come from clinical evidence, the pattern of recurrence. It tends to recur quite commonly, much more like a neoplasm than just a developmental cyst. There then is the link to nevoid basal cell carcinoma syndrome or Gorlin-Galt syndrome, in which the patients get other neoplastic lesions such as basal cell carcinomas on the skin. There's also genetic lesion, and that again to some extent links to Gorlin-Galt syndrome because that lesion is underpinned by the development of patched mutations in chromosome 9. And you can find them in odontogenic keratocysts too. But it doesn't appear to be particularly specific because patch mutations can be found in a number of other odontogenic lesions. And clonality, that's the whole concept of, does the lesion arise from a single cell of origin? And some people believe, and they've presented evidence, that odontogenic keratocysts do arise in that way, which would again suggest that it's neoplastic rather than just a developmental cyst. But in other ways, it behaves very much like more aggressive, but odontogenic cyst. And so in 2005, it was changed to keratocystic odontogenic tumor, and it was then reversed to odontogenic keratocyst in the 2017 classification. That's really where we are at the moment. So that's the end of section 2. And when we come to the section part 3, the last part, we'll talk about some of the other odontogenic tumours, benigns and malignant.